We were treating acute myeloid leukemia with 7 and 3 in 1977. We are still doing the same in 2018. What is the best way forward to change it by 2028?
Yes. Well, it's an honor to be with you, Azra. I've known you for many years, and these are wonderful questions that you're asking. Yes, we are still prescribing the same drugs for AML that we did when I was playing Little League Baseball as a second grader in the 1970s. However, the last time I attended on a hospital service 2 months ago on our leukemia inpatient service, it was the first time not a single patient on the service was getting the conventional 3 and 7. Everybody was either on a study, which of course is the way forward, or they were getting CPX351. They were getting, in addition to 3 and 7, midostaurin, or they were getting an IDH inhibitor, or they were getting a hypomethylating agent plus venetoclax. There was a lot of that. So we're starting to see some cracks, I think, in this 3 and 7 monolithic approach to AML. The best way forward, I think, is clearly breaking the disease into different groups and tailoring the therapy to what specific biology the patient's disease exhibits and into who the patient is, what their age and comorbid conditions are, and I think that's the way forward. We just haven't had effective drugs. That's been why we're so far behind, say, myeloma or lymphoma, where they have so many different targeted agents, and our myeloma colleagues now talk about pentarefractory treatment, people who've been through 5 lines of therapy. Nobody with AML gets to that point almost because, you know, it's such a difficult disease. So obviously we need more drugs, but I think we finally are starting to see some changes in how AML is approached.
Thank you. 3.5 million papers on cancer have been published. In 2017 alone, there were 135,000 papers. There's a staggering disconnect between great scientific insights and their translation to the bedside. What are we doing wrong?
That's a terrific question. You know, most of those 135,000 papers are in cell lines or murine models or artificial systems. And yes, that's important for generating hypotheses, but at the end of the day, we're treating patients. We want to make outcomes better for human beings. And we have made that process, we collectively, so bureaucratic and so difficult to do new innovative trials that I think that's really where the bottleneck is. A lot of those papers also are not innovative. They're Me Too observations. They're to pad up people's CVs. I think if we got rid of 90% of the journals out there, it would be no big loss. There's a lot of, you know, rubbishy journals out there, and so all of that I think contributes to these huge numbers. But we're not really being very efficient about cancer research. That, you know, I don't mean to be overly critical. There have been some huge breakthroughs, starting really with monoclonal antibodies and the tyrosine kinase inhibitors. And now, you know, we have immunotherapy, which certainly is something that many people are excited about. So all of these things, I think, are the type of advance that, you know, it just takes many years to really get the full benefit from and work out the kinks. And we've made that too difficult with our bureaucracy around trials.
That's a great answer. Very thoughtful. Thank you. Well, the fact that children respond to the same treatment better than adults seems to suggest that cancer biology is different, but also that the host is different. Since most cancers increase with age, that means having a good treatment may not be enough. Solution?
Yes. So I think in children with cancer, not only are they more resilient, and we see this even in a trivial way when a virus sweeps through our family, and my children recover in 24 hours, and I'm laid up for 3 days, you know. So they are more resilient, they bounce back more quickly, but also their cancers are simpler. Their cancers have fewer mutations, they often have a single driver, and as we age, we accumulate many mutations, and these tend to cooperate. And so if you look at the common epithelial cancers that people are diagnosed with in their 50s, 60s, 70s, and beyond, they have dozens, if not over 100 mutations, many of which are pathogenically important. So if you come up with a single targeted agent for one of those mutations, the best you're going to do is obtain a brief improvement and not cure. Whereas in a simpler cancer, a childhood leukemia that's driven by one translocation, you have a little bit of a better shot there. So I think it's both the disease and the host that are at play there.
Okay. You've great knowledge, experience in the field. If you were given limitless resources to plan a cure for cancer, what would you do?
I think it is difficult to know where the developments in cancer are going to come from, but it is sometimes a little bit easier to know who. And I think we have made the funding process too bureaucratic and too dependent on very conservative approaches. And I think that you know, if some of our best investigators were not spending all of their time writing progress reports and writing proposals in which for the 50th time they're saying how many people of different gender and race they're going to put on a trial, and or what types of mouse precautions they're going to take. You know, all of those things are important, but we don't need to keep doing that again and again and again. You know, get away from some of that bureaucracy. There was an article this week in the New England Journal. It was talking about the electronic medical record. It was called "Get Rid of Stupid Stuff." And I think, you know, that would help quite a bit, because the technology is there to move forward. It's just we sort of have to get out of our own way, I think, as a cancer research community, and to make the whole process less bureaucratic, and really, I think, channel our lead investigators into doing the things that they do well, and not the bureaucracy that tangles them up and wastes their time. You know, I think that's easier said than done. Of course, the NCI wants to make sure that their money is not being spent in crazy ways, but they're already spending it in crazy ways. So, why, you know, why, yes, you know, obviously, it's a complicated thing how we fund cancer research, and you know, I think that a big part of it that we can get away from is the bureaucracy, both in terms of the funding and in terms of trial conduct.
I see. Well, the final question, and this is more of a philosophical one, David. So I know that the thoughtful thinker and writer and physician that you are, you have thought about these issues many times. Offering patients with advanced stage, non-curable cancers, palliative but at the same time toxic treatments, is a service or a disservice in the current environment?
It's complicated. I think far too often we continue treating patients and offering chemotherapy without having the difficult discussions about what is really important to the patient, what is their priority, what type of risks are they willing to accept for a decreasing benefit. So I think that those are important discussions to have. I try to have them early in the course of the disease with my patients. Sometimes, you know, I probably wait too long. We certainly wait far too long to have palliative care involved with our patients, to refer them to hospice when it's time. The fact that patients with blood cancers can't get transfusions on many hospices is a barrier that we need to find ways to overcome, so that the patients can avail themselves of other hospice services. But I think that one aspect of this that is very difficult is that every once in a while we treat somebody with something that seemed like a long shot and they have a terrific response. And those are the kinds of things that, because it's so anomalous, stick in our minds. And so we want to keep going because the patient in front of us wants to keep going in hopes that maybe they could be that person. And maybe they could be that person. And it's hard, I think, to say enough is enough, or to have that discussion about when to switch care goals. I can think of a patient of mine who was hospitalized. He had had 5 different rounds of chemotherapy for his acute leukemia, and he happened to have an IDH mutation, and so we enrolled him on the very first cohort with an IDH inhibitor that has now, years later, been commercialized. I remember this well because I stayed up all night signing off his EKGs, making sure his QT interval was okay. I took a fax machine home and the nurses were faxing EKGs because there was concern about the QTC. And he went into remission after having induction chemotherapy and reinduction with high-dose Ara-C and a hypomethylating agent, and there was something else we tried. So this was his 6th line of therapy. And he went into remission, and he was able then to get a transplant. He went for 4 years without having recurrence of disease, great quality of life, got to see a new grandchild. And so, obviously this anecdote I'm telling you about because that sticks in my mind, but that's the exception to the rule. And, if we hold out hope for that in every case, then we will postpone the difficult discussions that we have to have in most cases, if that makes sense. So I think it's not an easy thing. It is a very difficult decision making as options close for patients. Sometimes the options are very poor right at the time of diagnosis. We see patients who we know are going to do poorly. In our line of work with myelodysplasia and leukemia, these are people with complex chromosome patterns and p53 mutations. They're not going to respond to anything well for long. They're not going to do well with transplant. We know this from day one. And those are people I think we have to start having honest discussions from day one, rather than pushing it off. So that's my philosophy, but it is when you're sitting in front of a patient, very difficult to say, really I think enough is enough. Although almost always people respond well to honest discussions because they're always thinking these things. Everybody worries when they have a serious diagnosis, what does it mean? And so often patients, it's a catharsis to finally have a chance for this type of honest discussion.
Excellent. Thank you so much. Basically, the consolation is that there is no consolation.